we have to find a way to move from where we are now to a system where we don't need to try all 11 drugs in a pathway to find the one that works, or we don't need to have somebody spend, a third of their residual income on medication when we know exactly what would work best for that individual.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. Thanks for tuning in on a Monday. So I have the privilege and the honor of having with me Dr Calum MacCrae. Dr MacCrae is the Vice Chair for Scientific Innovation at Brigham and Women's Heart and Vascular Center at the Brigham and Women's Hospital. I know that street really well. That's where I trained for my fellowship, just as a neighbor at the BI Deaconess Medical Center. Now, I think it's 10 years. 2015 is when I started my interventional fellowship at the BI Deaconess. So I cherish and remember those days with a lot of fond memories. So Dr. MacCrae has written some seminal papers. Some are hard for me to understand as a clinician on the trenches and as an interventionalist trying to take care of patients. And I'm sure he would sort of decode some of them for us. But he's sort of been at the forefront of precision medicine and cardiovascular medicine, which we know is an evolving target, not a moving target, but an evolving target, as we've come to understand of precision medicine over the past decade or so. So with that introduction, Dr. MacCrae, thank you so much for doing this for us. Welcome to Parallax. Welcome to the show, and look forward to this discussion.
Ankur, thank you for having me on, and please call me Calum. I'm excited to talk with you today. It's looking forward to it.
Yeah, likewise. Let's dive right in. I think for someone who is listening to this and who has sort of come across precision medicine and cardiovascular medicine, how would you describe it to someone who hasn't had a chance to sort of delve into the weeds of what precision medicine really is?
Very good question. I think, in essence, the whole role of a physician has always been precision medicine. It's matching the intervention to the risk and to the underlying mechanisms of disease. And I think the promise of a better understanding at a molecular level, at a mechanistic level of cardiovascular disease, I think led us into this, as it did in many other fields of medicine, led us into this field, this funnel where we believe that we would be better able to anticipate not only the therapeutic effects, but even adverse effects of medications or other interventions based on a much more detailed characterization of the individual before we started to intervene. And I think the reality is that to some extent, that has been possible, but to some extent, we're still, I think, taking quite a while to implement many of the insights that have developed. And I think one of the way I look at it is there are two challenges that have sort of stopped us. One is we haven't really been able to understand the mechanisms for many common diseases. And then on the other side, we haven't been able to be precise enough about timing on some of the rare diseases. And it's only as the number of different treatments for each of those avenues starts to proliferate that we've recognized we need to be better about matching patients to interventions. And then whether it's on the common disease side, where almost everybody seems to respond to, and in fact, almost every disease seems to respond to a GLP-1 receptor agonist, and on the rare disease side, where it's only as we have the tools and technologies to treat multiple diseases that we reach the point where the cost-benefit ratio for trying to identify and stratify those rare diseases makes sense, that we're beginning to see a rejuvenation of the field. I would point out that when I was, this was not yesterday, but it wasn't that long ago, when I was first in training, it was called molecular medicine. And its name has evolved 5 times, which is always an interesting sign. It tells you that things are not moving quite as fast as we would like when we've had to rename the same thing several times, usually once every 7 or 8 years, to make it seem like things are moving forward. But I do finally get the sense that precision is starting to happen. And I think one of the reasons that it's beginning to happen is the external pressures that I just described.
Yes. So, so for someone, for example, an interventionalist, who is taking care of patients in the throes of a STEMI, for example, we tend to now use the P2Y12s. I don't really want to call them novel anymore because they've been around for a while. Either prasugrel or ticagrelor. My go-to actually is ticagrelor in the setting of a STEMI. And then, not infrequently, I encounter patients not being able to take ticagrelor. For the vast majority, unfortunately, due to cost, it becomes a factor for a lot of these patients. And then you have a subset where it's either bradycardia or dyspnea exertion. And so we transition them to clopidogrel. We sort of give a loading dose of clopidogrel again, and then transition them to clopidogrel. I tend to get a platelet reactivity unit to make certain that the platelets are adequately inhibited. Is there a better way to decode this? I mean, I think from a geneticist and a cardiologist, in you, is there a better way to do this up front?
No, absolutely. So you can imagine. So if you think about what you just described, so there are 3 or 4 points in the workflow where you could add information content and be really much more precise about allocating the agents in the way that you would like. And that covers everything that we talked about, everything that you talked about. So it's not just molecular mechanisms, it's insurance plan, it's their willingness to supplement their existing copayment, as well as their ability to metabolize clopidogrel, the basis of their adverse reactions to ticagrelor. Those are all information. Those are all insights that we could glean from prior information content if it was collected in a systematic way. But in general, what we tend to do is we tend to collect it after the event. And that post hoc collection has 2 problems. One, it doesn't really improve cost or efficacy. You're still ending up probably going through the same sorts of motions that you would have done even 25 years ago, before the mechanisms of these things were not obviously known and before some of these drugs were available. But in addition to that, I think there's also the tendency for that information not to be collected in a way that it improves your ability locally or our ability more broadly to change the workflow. And so I think that's one of the things that I feel quite strongly about, is that we're part of the issue. So for example, if you think about how you would want to collect data to address exactly the question that you just outlined, we'd need to have a priori information on the pharmacogenomic responses of individuals to clopidogrel, to ticagrelor. We need to have some sense of their baseline willingness to spend time and money in each of those domains over the duration of their treatment for their ACS. And in addition to that, we'd have to have the ability to improve workflows to be able to implement any lessons that we had learned. And at each step, we've not really built in systems that allow us to do that in a generalizable way. So we're dependent on a new drug. Like when clopidogrel came along, there was quite a large investment in the genetics of clopidogrel because it was the only game in town. And so people wanted to avoid the problems of clopidogrel resistance, but then very quickly there were new P2Y12 inhibitors available, and they had no real vested interest in understanding clopidogrel resistance or interactions. They were moving on to what are the risks and benefits of their particular agents. And those are relatively modest incremental benefits. You can argue there are some significant benefits, but they're not so dramatic that you would have necessarily spent the, probably hundreds of millions of dollars, maybe a couple of $1 billion that it's taken to essentially refine the P2Y12 space to the point where it currently is. And I'm sure there are still, in fact, I know there are still sort of, next generation P2Y12 inhibitors coming down the pike because people recognize there are still ways to influence this market. And yet we're still sort of stuck in a position where all of the data collection, all of the investment in understanding human disease, all of the investment in understanding our workflows has to come from third parties because we haven't built systems that allow us to collect that information in a meaningful fashion. And, the example I always give is COVID, where 1.5 billion people had exactly the same disease with exactly the same mechanism, all in about a 2-year period. And all of the useful information that was collected came from 5,000 people in Israel and 5,000 people in the UK. And everybody else's data were thrown away. So think of how many ACSs have been treated in the US in the last decade and how little information we've learned in the real world about how to manage exactly the workflows that you just described. And so there's probably a bespoke strategy in almost every single IDN in the US for how to deal with that. People either ignore it or only deal with it at an individual practitioner level when something happens like ticagrelor is too expensive or there is an adverse effect. And there's not really a platform for learning how to do this in a systematic way. And I would argue that's part and parcel of why we've ended up in this situation is we're stuck with the information that people have decided they're willing to pay for. And we as a profession have not built information that would help us manage our patients much more precisely. So I'm not being critical of the pharma companies. They're spending money where it makes sense. But we've sort of, I think, acquiesced to some extent in building a system that's responsive to problems rather than a system that proactively identifies what those problems are likely to be and how to manage them. And it's only as those incentives are aligned with external players that we're starting to see a convergence of efforts to try and solve that. And there's some great examples in the rare disease space where, suddenly when you have a drug that's quite expensive for a condition that's quite rare, you need to build tools and technologies that don't wait for people to show up. They go out and identify those people before they actually have a problem. And so, as I said, I'm actually very pro-industry. I think industry is the place where a lot of the funding for this innovation can come from. But I just worry that we have not really thought through how we could participate in this independently from pharma funding so that we could learn the lessons we need in order to better use data between those inflection points that are pharma funded.
Yeah. So this is fascinating. So this is sort of like the intersection is of that of precision medicine or molecular medicine and learning health systems where, there are system factors or system effects, and then there are, factors which are attributed to the individual that you're taking care of, and there needs to be a marriage of the two scenarios or cohesiveness for us to deliver personalized medicine. So in an ideal scenario, if you were to design a patient experience or a patient interaction in the terms of a STEMI with a healthcare system in a personalized medicine sphere, how would that look like for you?
That's a great question. So I obviously have thought quite a bit about exactly this. So I think there are a couple of challenges that we haven't addressed that dictate the direction that would go in. So one, I think is, and this is, I'm not trying to be critical. I'm just pointing out challenges because you asked me where those challenges are. but the reality is one of the biggest barriers turns out to be the electronic health record, because there are lots of ways in which that has slowed down the implementation of precision medicine. First of all, we spend most of our time entering data. It's almost an embarrassment to realize how much of our time has gone from looking after patients to entering information that many instances has already been entered. The second thing I think that's quite obvious from the EMR is that it tends to record a lot of information about us and not very much information about the patients. The data content of a medical record, when you eliminate the objective data, is really quite sparse. I mean, most of it is, sort of Homeric odes about the patients. We tend to dictate notes. We tend to interact with patients the ways that we were taught, not in terms of collecting rigorous and objective analyses of how their clinical care has progressed. And then the other thing that I think is a huge problem is that we also make it very hard for people to share their data with anybody other than the people they're already engaged with. A final sort of element of the EMR is that it is essentially blocked out 90% of the data that have emerged in the last decade. So there's no genetics, there's no wearable data. There is virtually no personal data. There's no family history. I mean, the family history has gone from being a beautifully outlined 3-generation pedigree to 2 brief lines in I won't name individual EMRs because that would be invidious, but 2 brief lines in an EMR where it's sort of a plus or a minus, and there's almost no detail between, I've got a couple of people who died of something vaguely related to their heart, and I have a 5-generation autosomal dominant history of sudden death before the age of 30. Those 2 things look almost identical in the current EMR. So I think the solutions, so that's one set of challenges. The second set of challenges is that the cost of adding information content to medicine has reached the point where it's prohibitive. So it's, as I said, and this is actually in favor of doing the things that I'm going to tell you about, because it would actually dramatically reduce the costs for all of the players, not just us who are dependent on clinical revenue to support and modify the systems that we use, but on the payers and on pharma, which are the real sources of remuneration in this entire industry. Those costs would be much diminished if there were much more efficient ways of learning insights in a systematic way. And just even how long it takes to get a biomarker into the clinic and how haphazard that is one of the things I think that changes how efficiently we can implement precision medicine. So a couple of good examples there. I think, cardiac troponin T is probably a fantastic example. It's now, I think, used in almost every single emergency room admission. If you move slowly through our emergency room, you'll have your cardiac troponin checked, even if you're just visiting. And the reality is that because of the fact that we haven't characterized the pretest probabilities adequately, we get false positives that are probably, a third of all cardiology consults. And in most hospitals today are false positives for biomarkers. Maybe not quite as high as that in some settings, but it's certainly in that range from the published literature. At the other extreme, as I said, there are data types that are incredibly efficient at identifying mechanism and predicting the use of a certain set of drugs. Let's say clopidogrel. For $25, you can get almost all of the pharmacogenetic information in your entire genome nowadays, and none of that is in the record. So you could have been saved quite a considerable amount of work if you had known exactly what that your patient's genotype was at CYP2C19, amongst many other loci that we can get into. But the reality is that because of those features of the current system, I think one of the things that we have to really think about is how do we begin to add information content in medicine without having to involve the current mechanisms for doing that. And so one of the ways that I imagine this will be done is to give the patients, before they're even patients, to give individuals much more control over their own data so that they can decide when and how they begin to collect their data. They can be the arbiters of where it ends up. And modern technology, I think, is much suited to this. I always point out the fact that I've given out my credit card 3 or 4 times today, and it's probably much more valuable uh, to me than any of my medical information. And certainly, I'm much more concerned about people getting a hold of my credit card than I am about getting a hold of my systolic blood pressure. But the reality is that we've made it very difficult to exchange that information. So one of the ways to overcome that, that we actually spent quite a lot of time on when we were working with Verily and AHA and AstraZeneca and in the One Brave Idea project, was to try and give the individual much more control over their own data, to have use-specific consent, and to allow people to take the information that they have and to send it or cede its control wherever it is. That does a couple of things. It also allows you to use information that may not be necessarily part of the traditional EMR and begin to use it for predicting your health and wellness, and for setting the pretest probabilities for some of the more medically oriented biomarkers that we talked about. So if you had, let's say, for example, 3 decades worth of your own information on hand before you ever showed up to see a physician, and it was in a format that allowed you to be able to use it in healthcare, use it in banking, use it in transport, then suddenly you would have the ability to be able to predict the things you wanted to predict, to be able to have the precision you wanted for the actual decisions that were going to be made in front of you. And you wouldn't have to start collecting the data at the point at which the problem had been identified. In fact, you would have anticipated the problem long before it currently existed. If you talk to any of the major pioneers in digital technologies and other industries, they will always tell you that all you need to disrupt healthcare is to be able to predict an event 30 minutes before the current system predicts it. And at the moment, the current system waits for you to come in the front door. So if you were able to predict incident events, if we had built systems to do that, we would be in a much better position then to manage asset allocation in acute medicine, to prevent chronic disease becoming acute disease, or intervene in a much more targeted fashion in the windows of opportunity when chronic disease transforms into more acute phenomena. So I think all of those things would be better served by having the data be better managed by the individual. And the other thing I love about that is it also engages the individual in their long-term prevention and care. And you're also building a very clear sense of what those individuals would like for themselves. So you might even have been able to ascertain whether they really wanted to spend however many dollars a month extra it would have been for the ticagrelor, or whether they would prefer just to take that incremental risk, modest though it is, and pay for the $25 for the CYP2 C19 genotyping 10 years earlier. Those are the types of trade-offs that I think exist in most other parts of our lives. And if we build those types of knowledge or information gathering platforms, then a lot of what we're doing subsequently is really learning from the iterative use of that information, adding more information content and adding actual outcomes. And that's the other end of this piece, I think, is that we need to build medical systems that add information on biologically relevant transactions. They don't add information on what we did. They added information on what actually happened to the patient when they were exposed to, let's say, ticagrelor, or when they were exposed to a beta blocker or a vasodilator. Those are the types of things I think that would really start to change the way that we imagine how healthcare can be delivered. So, when I was chief of cardiology at the Brigham, we built out a algorithmically driven management platform for hypertension, for lipids, because they were, I think, pretty rational places to start, and for heart failure, because it's a little bit more complicated. We thought we'd do that as a sort of countervailing example for more complex intervention. And when we did that, we found that not only were we able to execute reliably, in a way that the current system does not. Even in North America with commercial insurance, you probably only have somewhere between a 55 and 60% chance of still being on a statin a year after your index vascular event, either coronary or cerebrovascular. And similarly, for blood pressure, most people are not at goal after 18 months to 2 years in the current system. And so finding strategies that allow you to execute on the things that we know already make sense, I think is a very useful way of thinking about this. And how would you do that in a way where you can use the information on responses to then change the way in which you apply, in a principled way, the next steps in the algorithm. And when we did that, we were able to show very quickly that you can identify people with renovascular hypertension within a couple of weeks. You don't need to be 2 or 3 years in the system if you just have the right measurements made at the right time with the drugs delivered in a principled and ordered fashion. And so, I don't want to make this out to be more than it is. None of this is rocket science. It's just collecting data in a systematic way about the information that's important in order to then make the intervention more precise. And that can be everything from timing through to your responses to the initial agent. And we don't really do that in any rigorous or systematic way.
Yes, so I have, these are great insights. I have a couple questions for you as a follow-up to that discussion. One is, as you said, this is not rocket science, it's data collection. Question is, why do we we can talk about different health systems, but I think if you were to just take an eagle's eye view from a healthcare perspective in this country, because when I was in London finishing up my economics program at the London School of Economics last year, the one slide which kept showing up again and again was how much we spend as a country in our health system and in healthcare. And then we were juxtaposed to other developed countries where they spend a fraction of our GDP, and yet the outcomes, the clinical outcomes, are far superior. So the first question is, these are simple steps. Why is there? Well, a better way to phrase it is, what do you, according to you, and based on some of the work that you did at Brigham, what are some of the challenges or barriers that health systems face in general, which makes this more actionable or more pragmatic, or sort of like point of care knowledge available to act upon immediately for the next patient that enters the door?
That's a great question. I think I can run a list of the things that come to mind. I'm sure there are. Part of the problem is when you've worked out why it happens in one system, you've worked out why it happens in one system. I trained in the UK, so I know the UK system very well. And I came here deliberately. I think one of the things that's very obvious is that there is a degree of innovation and dynamism in the US system that, certainly 25, 30 years ago when I came was quite different than it was in the National Health Service. I think the same financial constraints have started to impact the NHS in the UK, and you're seeing a convergence of exactly the same challenges. And that leads me to believe that one of the things that it's not is the amount of money that's being put in. I think it's where the money is being put in and what the intrinsic barriers are. So I think there are a couple of, and I'll make these comments again, I'm literally just responding to your question with thoughts and ideas in the order in which they come into my head, which is always dangerous. But the biggest challenges are things like, what other industry on the planet is research and development a separate industry? Like that was I don't fully understand how it evolved. I do know how it happened. It was due to conflict of interest. But the reality is, nobody's more conflicted than the patients in this. They need the new therapies. They need them applied in the right way. And we've convinced them to basically allow us to be the brokers in all of this. So that's the second piece. The second piece is, when we've analyzed a lot of what happens, where the problems are in our system and other people's systems, the block is always the provider. The block is that most providers feel, and this is an interesting challenge, because at the same time as we feel like only we can fix it, we are the artisanal designers of blood pressure regimens for our patients. We're the artisanal investigators for this complicated condition that afflicts only the people that come to see us. And the reality is that, common things occur commonly. Even rare things occur pretty commonly when you look at them globally. And most other industries have worked out ways to combine strategies that deal with the common and the rare. And what they don't involve is having an artisan in every single office refashion from scratch what they think the truth is on a regular basis. And that's basically how medicine works. For things where even where there's a ton of evidence, we can't deploy that evidence. There's I think the data for, particularly in cardiovascular, are very strong, that it's somewhere between 12 and 15 years after something reaches the guidelines, before it's fully implemented across the US. So, and I don't think it's any different in the UK. So I don't think it's a function of the resources. The other thing that's a huge problem is that we as providers we're completely overloaded. That's partly why we end up in the situation that we're in. So if you think about it, when you trained, probably less so, but when I trained, you were literally expected to know absolutely everything in one head. And so your brain had to contain all of internal medicine. And as a result, there was this sort of misconception that suddenly you could literally bound the knowledge base very clearly by what one person knew. And that is just no longer the case in any profession, but it's certainly not the case in medicine. And I'm actually following the situation in the UK at the moment, where I'm seeing junior physicians, early trained physicians, so early attendings, complain about the fact that the healthcare system is trying to give more responsibility to mid-level practitioners, when in fact that's the real problem. Is many of these things should long ago have been ceded to the patients themselves. If the evidence is clear, why are the patients not involved in implementing their own care? Why are they not titrating their own medication? They do in certain settings. I mean, we do it routinely in heart failure with diuretics. We do it routinely in anxiolytics. We do it routinely in other situations, but we've sort of held on to stuff with white knuckles rather than thinking, okay, where is the evidence base sufficient to allow the individual patients to manage their own information and make sensible and informed choices, with the ability to talk to us if they need specialist or even generalist help. And so I think the two things I would highlight there that have been barriers. One is, again, the intensely local and artisanal nature of medicine. There are no systems. Population health, which actually is quite well developed in the UK, has still not been able to overcome some of the challenges that exist from this sort of sacrosanct nature of the patient-doctor relationship. And that's something that we, as physicians, I think don't get me wrong, I love looking after patients. It's it's probably the only thing I really do. But the reality is that to overemphasize the importance of the individual, I think, is a mistake in that relationship, except for where the individual is the patient themselves. And I think what we need is the best information flowing to our patients in a way that's unencumbered by the barriers of workflow and clinical training that we've put in place for good reasons, but which have, in many instances, outlived their usefulness because the evidence exists to be able to bypass us. And you saw some of that trust diminution during COVID. When you hear physicians go on online or on television and give perfectly dogmatic opinions that then are reversed 48 hours later, you're not admitting the uncertainty that really exists in human biology. And I actually feel that part of our problem is we've made everything more uncertain than it is where it is certain. And we've made everything less certain than it is where it is uncertain. So we've ended up in this situation where, almost as a means of trying to balance the tensions of being a busy and professional in a massively proliferating information-rich environment, we've sort of ended up making subjectively the wrong choices for us and for our patients. And I think we need to sort of radically rethink how healthcare is staffed, how information flows through healthcare, and how that information can then be used by everybody in the system, but most importantly by the patients, to deliver the best outcomes. And much of that, I think, is going to happen, unfortunately, outside traditional medicine, because we've sort of boxed ourselves into a position where we have no investment capital, because the margins in healthcare now are so tiny that even the richest systems in the world can't afford to invest in the system redesign that would be necessary. So those are the types of things I think that are the major challenges, and I see them both in the UK and in the US, perhaps to a slightly lesser extent in systems that are less centralized and less distributed. But I think the same fundamental flaws are challenges worldwide.
Yes, and boy, it's complicated, isn't it? It is, and I one more question which I grapple with, and I've sort of thought about this. We keep coming up, and not that these aren't drugs or solutions that we need. I mean, we do need them because we keep seeing benefit, and this is sort of piggybacking on one of the comments you made earlier, is to get the patient involved in their own decision making as to whether or not they want to invest that money in ticagrelor versus CYP2C19 testing. It's a similar analogy, this question. And that is, like, we keep coming up. I mean, if a standard patient, a standard cardiology patient in 2025, post MI with ischemic left ventricular systolic dysfunction, needs to be on dual antiplatelet therapy, needs to be on quadruple backbone guideline-directed medical therapy for reduced ejection fraction, needs to be on a lipid-lowering agent. If, God forbid, their triglycerides are elevated despite a well-controlled LDL, now they need to be on, icosapent or, you need a second lipid-lowering agent. It's sort of like a class 1A in the new guidelines by ACC-AHA. So, I mean, you're talking about at least like 7 or 8 drugs. And, you throw a tincture of atrial fibrillation there, and now, there's, dual antithrombotic therapy. So it's like 8 or 9 drugs, of which, I mean, ticagrelor is not cheap. Apixaban, rivaroxaban are not cheap. Evolocumab is not cheap. Icosapent is not cheap. In patients who don't tolerate statins, well, bempedoic acid is not cheap. Or for that matter, the combination of bempedoic acid and ezetimibe. None of these are cheap. And then you're sort of like, okay, I'm gonna let go of the sacubitril valsartan, just do valsartan, do a beta blocker, maybe throw a bit of an aldactone, see if you can get by rivaroxaban or apixaban. I mean, will personalized medicine help us in determining which of these medications are actually going to be most beneficial for that particular patient?
You make an excellent point. So one of the things I think that's really fundamental in all of this is, if you look at that repertoire of guideline-directed therapies, virtually none of them have been tested in different sequences or tested against each other for long-term outcome benefit. And that's before you even start to think about price. So in terms of bang for your buck, or the order in which you would give agents, it's largely driven by our preferences or by side effects rather than the data. If you look at the guideline-directed medical therapy, every single trial of every one of the GDMTs for LV systolic dysfunction was tested in the context of prior standard of care. So nobody's ever tried the last drug without any of the first 3 drugs or the first 4 drugs. And so that's the type of question that would be answered very, very quickly in a learning system. That's the type of question that would be answered, within weeks, if we had platforms that allowed everybody, because as you point out, acute coronary syndromes making it to PCI, that's probably 500,000 cases in the US a year, certainly over 350,000. And so you're beginning to see that you could answer these questions, would have been asked and answered at very low cost. And people would actually have robust insights into how best to manage each of those individuals based on a whole host of other parameters that we don't have time to discuss. So I strongly believe that that is part of what the driver is going to be for beginning to think about how we redesign the whole system from scratch. But as I pointed out, the reality is I don't know that we have the bandwidth financially or intellectually or even in terms of the sheer capacity of our systems to do this in a really robust way inside the current fully engineered care delivery platform that is U.S. medicine. I mean, even the richest systems on the planet can't afford to ignore the current sources of revenue and their very narrow margins. So I think it's going to require either stealth entities that we haven't yet identified or action by federal governmental players to really think, how do we begin to incent redesign rather than incenting better cost in the current system, which has, I think, to a large extent shown itself not to be completely fit for purpose. And that's not to be critical. I mean, I think it's such an amazing situation to be in, to have so many really incredible therapies that have, actual mortality and morbidity benefit. I think the question is, how can we begin to do this so that instead of doing it as a series of one-offs, we're able to do it almost as an optimizing function? How can we begin to build into our care delivery platforms the ability to optimize for the individual in a way that is transformative in our lifetimes? And I certainly see what's happening around us in other industries as being able to do that. People have, partly as a result of collecting better data, partly as a result of using better analytics, they've been in a position to improve things like, and it's still not perfect by any manner of means, but things like credit card fraud. Look at how travel has been democratized and to some extent cheapened by the availability of information and empowering the individual to make the choices and to make the trade-offs that before would have been in the hands of a third party. I think we have to find a way to begin this process. But I totally agree with you. You just highlighted, and that's just one specialty. Can you just start to think about, oncology, you start to think about chronic rheumatologic conditions, and you start to see just how incredibly slow the process is for information gathering and insight delivery in a way that wouldn't be tolerated in any other setting. I mean, almost every time you open a web page, somebody is A/B testing some advertising algorithm, and they've learned the answers within minutes worldwide, tailored for individual cultures and languages and backgrounds. They don't need 15 years of external investment to be able to work out, is it good to have blue in the background on this banner on your website? They know one way or the other within a few minutes. And so we have to find a new way of thinking about things and do it. I mean, don't get me wrong. I work in the current system. I've deliberately stayed in the current system because I think the solutions have to come from within. Because the best thing about medicine is and the associated entities, biopharma, biotech, technology, we have literally changed the game. There are so many amazing things for us to be thankful for and glad for in modern medicine. We can't throw away the baby with the bathwater, but we have to find a way to move from where we are now to a system where we don't need to try all 11 drugs in a pathway to find the one that works, or we don't need to have somebody spend a third of the residual income on medication when we know exactly what would work best for that individual. So I think finding the way to do that and to build trust with the public around doing that, I think, is a super important goal for medicine over the next few years. Probably not what you thought you were getting into when you asked me to speak about this. But I think the traditional model of precision medicine is we measure genetics, we know what's going to happen with everybody, and we're all done. But the reality is, even in Mendelian disorders in North America, which is the single most well-funded healthcare system on the planet by probably a factor of 2, only 5% of people who have an autosomal dominant cause of sudden death or heart failure or vascular disease will ever get tested genetically. So that tells you how far away we are. And the technology has been completely stable for 15 years. Nothing has changed in sequencing in 15 years. And yet we just can't get stuff into the clinic. And there are lots of reasons for that, which we've talked about already. But that's just a marker of how far we are from being able to realize the vision that there was molecular medicine, personalized medicine, precision medicine, you name it, what you like. It's still the same basic thing. It's treating each patient as an individual. We're so far from being able to do that I think we do need a bit of a radical real reassessment of what it is we're doing collectively and think about how we can all work together with both inside medicine and entities outside medicine to build something that's fit for purpose.
Oh, it's been a fascinating discussion. Thanks for the insights, and thanks for diving deep into this conversation. You have any closing remarks for our topic, for our listenership, and any closing remarks for Parallax?
The only thing I would say is it is the most exciting time to be in medicine probably in the last 200 years. And that's something I think that's really important because we're going to need to attract the very best people, and we're going to need to work together in a very different way than we've worked over the past 100 years in order to really change the way that medicine is structured and the way that medicine delivers. Even the insights that we already know can be impactful, far less the things that I hope we'll be able to develop in the next few years.
Awesome. Well, thank you. Thanks again for everyone who's tuned in to listen. Do share your feedback. If you have questions for Dr. MacCrae, you can send them to us on our email, which is listed in the show notes. And do share your feedback with us. We take it seriously. If you have suggestions on other guests like Dr. MacCrae that you wanna listen from, do send those names in, and we'll try our best to get those on the show. And until other Monday, have a good day, everyone.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.